Good morning. We'll go ahead and we'll start the cardio lecture. And wow. Okay, let me just get this over here. Okay, so if we talk about the cardiovascular system, and really the heart's job is basically the heart is a pump and it has hollow chambers, the atrium and the ventricles, and that holds blood. And it is connected to a series of tubes or vessels. And this blood is pumped as a figure 8 through the body. Okay, so the whole cardiovascular system is connected, and it is a series of these tubes. But its job in that blood, we have nutrients, you have hormones, antibodies, electrolytes, but there's also stuff we don't want, waste products, drugs that we're using. So as the heart is pumping continuously throughout the body, it's like a transport system. And again, all of those vessels are connected to all the parts of the body, the muscle, the liver, the kidney, the intestines. And when we've talked about drugs with you guys and hormones, there's always targets, but hormones and drugs have to travel through the blood to get to where they need to go. So adequate circulation is key for transport of drugs, transport of nutrients, oxygen, and such. So they carry blood away from the heart to the rest of the body, and veins are going to bring it back. Okay, so if I click here, and there's 5 million different pictures of the heart, but when we're looking at it from the outside, one thing is you're looking at, now remember, this is enclosed in a pericardium. When we talk about diseases, that's important because there's a sac, the pericardium, there's a space. It's not supposed to be very big, and it does have fluid in it. There's supposed to be a little bit of fluid called pericardial fluid. So it allows the heart to beat within that sac. You can see how it branches. So we've got different branches. This is obviously with its being red here. This is going to be the aorta. And then over here, this is actually the vena cava coming back in. So we've got right atrium, right ventricle, which I think everybody got right yesterday. It's like that's deoxygenated. And then the left side, you have the left atrium, the left ventricle. And this big red vessel here is the aorta. And then you remember when it leaves the right ventricle, because it doesn't have oxygen, if you look here, it's going to split. So it comes up out of the right ventricle and then it splits to both sides of the lungs. So the pulmonary artery, remember, arteries are away, artery away, venous return, artery away. So an artery almost always has oxygenated blood. This is the exception to the rule. We talked about that in anatomy, is that the pulmonary artery does not, because it's going away, that's why it's called an artery, because of its direction. But the blood is going to the lungs to get oxygen. So it's deoxygenated when it leaves, and then when it comes back in, well, let me get to the next picture because maybe there's a better, here we go. If we look in the back, this is the posterior view over behind. You've got the pulmonary vein. Now you see there's 2 here and 2 here. Oopsie. So those are coming back in together from the right left side of the lungs, comes back in to the left atrium. And then remember, the vena cavas that are coming back are bringing blood from the body, from the front half and the back half. So you have superior vena cava. Some people call it cranial vena cava. I'm going to pause. I don't know if I paused. Every once in a while I get a box that pops up. It says my computer internet is unstable. So if I paused, sometimes I just stop till that little sign goes away. So superior is coming from the front half of the body. Inferior is coming from the back half of the body. Hopefully I'm unfrozen now. I don't know what my internet issue is. Okay. Now, sagittal view is the heart cut in half. So they've sectioned it out. Here's the aorta. Now, if we look here, if you remember, there's what's called the interventricular septum that separates the right and left sides. Remember, blood should not go laterally. It goes from the right atrium to the ventricle and then out the vessel in the same direction. We talked about those fetal abnormalities like a foramen ovale. A foramen ovale is like a hole in the heart, and that's where there is a defect or an opening in the septum, and it allows blood to go between atria or between ventricles, and that's abnormal. And then you got the valves. If you remember, we've got the tricuspid on the right, and the mitral is on the left. And remember, mitral has an L in it, L for left. So that's how you can remember the mitral valve is on the left. A lot of times they'll say a dog has mitral regurgitation or abnormal flow. We're going to talk about these valves like a gate. So when the atria contract, that valve should open and allow blood to go to the ventricle and then should close. It shouldn't allow blood to go backwards. That's where you get the murmur sounds and that turbulent blood flow, is when for some reason, and it can be only one, like if it goes like this and then one side goes like this. And what's happening is it's allowing some blood to go backwards and then it causes this abnormal flow, and that's the swooshing you hear on a murmur. Okay, so when we get into murmurs, that's important. When we get into the myopathies, since I'm on this picture, myo is muscle, pathy is disease. There's going to be two forms. Now, I didn't, on the discussion board, I didn't specify because some people just put one of the diseases is cardiomyopathy. Remember, there are two forms of cardiomyopathy, hypertrophic and dilated. Cats typically get the hypertrophic, which is a thickening. This muscle gets very, very thick, and it decreases the size of that chamber. So the thicker it grows, they cannot hold as much blood because the chamber, it's kind of like if you take a cup and you add a bunch of thickening to it, your cup's not going to hold as much. Think of it that way. Now on the flip side, dilated cardiomyopathy, this muscle here is very thin and very weak. So what happens is when the heart pumps, instead of being a very nice, consistent pumping, it's kind of like, it's very weak and very kind of flaccid. And then it's not pumping out blood well enough. Okay, so those myopathies cause different problems. They show different clinical signs. They're both a disease of the muscle. The dilated cardiomyopathies we see in like our Newfoundlands, Dobermans, can even be sometimes in boxers, and things of that nature. So just when you're looking at this, you've got myocardium, epicardium, endo is within. If you know, people, we talk a lot about endocarditis in people, is if you get an inflammation of the lining of dilated and what? Dilated cardiomyopathy. I'm going to type it in here. If I could type. Oh, I just sent that to Miranda. I'll give it to everybody. So those are the two forms. I just typed it in the chat of cardiomyopathy that we see. Now I've just said this, but veins, always remember, veins carry the unoxygenated, deoxygenated blood from the tissues throughout the whole body back to the heart, and arteries carry away. One of the things I want to mention here is veins. There's a little line here. Veins are basically, they're thinner and they carry a greater volume. If you remember from anatomy, the veins are typically, they do not have as much muscle. They have valves that prevent backflow, but the arteries are stronger and they are thicker. Sometimes they don't carry as much blood, but they have a lot more muscle and they can change their diameter based on input from the body. If you remember when we talked about the nervous system and fight and flight, and we talked about those stress hormones, and basically like norepinephrine gets released, it goes to the vessels, and remember I said it causes vasoconstriction. So it's going to change the diameter, it changes the muscle tone, that way blood is sent to the appropriate tissues. So this is how it reacts with these vessels. Let me type in breeds. So I said, I'll add one. I can't remember what the other one is. I said Dobermans, Newfoundlands, Irish Wolfhounds are another one that we would tend to see some of this dilated cardiomyopathy boxers. How could I forget that? Okay. So know the difference between, so I said the left side of the heart receives oxygenated blood from the lungs and it's going to send it to the rest of the body. The right side of the heart receives carbon dioxide rich blood. Remember, it has a lot of carbon dioxide from waste and from the body. And it's going to send the blood via, this blank says pulmonary artery. So and the second one is the pulmonary veins. So the first one there, it should say pulmonary arteries. That's why I talked about it goes to the lungs to oxygenate. That's the exception to the artery vein rule. And then the pulmonary veins carry oxygen-rich blood back. Okay. Now, I already kind of talked about that. The vena cava, remember I call that the mama vein. The aorta is the mama artery. The vena cava is the mama vein. It's the biggest one in the body. They're both the largest vessels. The vena cava is getting blood from the cranial and caudal part of the body. So the first blank there should say cranial, then caudal. In your PowerPoint, it called them inferior and superior. Now, sometimes books will, superior is coming from the front half, inferior. I prefer to call them, and most people call them cranial, caudal, vena cava. Cranial coming from the top half, caudal coming from the back half. And then the aorta, I'm really sorry, it's going to leave the left ventricle, take blood to the whole body. And I think I just answered these questions when I mentioned earlier. Mitral left. Mitral's the left side, tricuspid is the right side. Now, those are valves in the heart. In anatomy, we also talked about the aortic valve and the pulmonic valve, because when the heart's in contraction, when the ventricle squeezes and blood is going to go out that aorta, when the heart is in diastole, which is relaxing, that aortic valve will shut to help prevent what's sitting in the aorta from moving backwards. So there is valves at the aorta and the pulmonic valve. So you can get there. Now, if we talk about AV valves, Basically, the right there should say tricuspid and the left should say mitral. Those are the proper names. They are sometimes called AV valves because they are between the atrium and the ventricle. So if it's an AV valve, the right AV valve is the tricuspid, the left AV valve is the mitral. That's all that it's trying to say. And then I just explained the aortic valve is at the level of the aorta, and it prevents backflow into the left ventricle, and the pulmonary valve prevents it from going back into the right ventricle. So 2 in the heart, 2 at the levels of the valve right at the heart, keep all that going in the right direction. We never want backflow. Backwards flow creates turbulence and abnormal flow, and turbulence creates problems. And that's what we're going to talk about when we talk about diseases, is what is the consequence if they have a leaky valve or they have a valve that won't close properly. Okay, now I want you to think of it this way. Everything I just talked about is a mechanical function. Pumping is mechanical. Closing of parts, think of these like machine parts, okay? If any of these are not working, valves, pumping, turbulent flow, those are all a mechanical issue. What we're going to get into is the electrical system, because that is basically, the electrical system is supposed to initiate the heartbeat and the proper flow of the impulse. And that is called electrical activity. So think of conduction, electrical conduction through like electrical wires. Like when you flip on a light switch, the signal should go to the light and your light should come on. That, you know, if you get the flickering or something's not working, it could be an abnormal conduction. So what happens in the heart is the SA node, sinoatrial, and wow, you find it in the right atrium, sinoatrial, it's found in the atrium, initiates the heartbeat. That is the pacemaker. So it is beneath that endocardium, so within the right atrial wall, this little node is embedded. When it triggers, it is going to go through something called the AV node. Well, where do we think we find the AV node? Maybe between the atrium and the ventricles? In anatomy, and if you're having trouble with this, I urge you to go back and find your cardio notes. I gave you this kind of blown up picture of the heart with the conduction system. I can always see if I can find it and send it to you, but you should have it in your notes. And it talked about the flow and where you could find this. So it goes SA node, AV node, then it's going to go to the AV bundle, which is also called the bundle of His. And that's when it moves down to the ventricles. So once it leaves the AV node, it divides into that bundle of His. And let me go, actually, sorry. So the one thing that's not on here is bundle of His, then to so it goes AV node, bundle of His, and then the bundle, it's like a bundle of wires, it splits into the ventricles. What the heart is trying to do is signal the atria to contract. When they fire, it should trigger those muscle cells. It triggers a wave of conduction and the muscle cells contract. But remember, the heart doesn't squeeze all at once. The atria are supposed to contract, push the blood to the ventricle, then the ventricle contracts. Now that happens very fast. When you feel or hear a heartbeat, you're not really telling the difference. I mean, the lub-dub, if you have a dog that a very loud, slow heartbeat, and you hear the lub-dub, those are the different valves closing, and that means they're closing at different times, and that's a normal conduction through the heart. So SA to AV, bundle of His, Purkinje fibers, atria contract, then the ventricle will contract. So what happens here is we get a normal conduction through the heart. If you remember, though, I stressed in anatomy, electrical and mechanical are supposed to work together. Electrical triggers a contraction, the heart squeezes. But there are times in certain cardiac arrest or critical patient where potentially the heart has stopped, but the electrical system will keep trying to fire. And we call, remember, and I'm going to get into this in diseases, but we call that EMD, electromechanical dissociation. I'll type that. Sorry, I'm typing challenged. Electromechanical dissociation, and literally that means electrical and mechanical activity has disassociated from each other. Now, if you ask me what I'd rather have, I would rather have my heart pumping. I would rather have mechanical activity. Hopefully they work together. But when I get into arrhythmias, which is an abnormal rhythm, a lot of times that's an issue with the electrical system, and that triggers an abnormal heartbeat. So arrhythmias can be a symptom of abnormal activity in the heart, but an ECG always has to be taken with a grain of salt. An ECG, an electrocardiogram, is going to confirm if this electrical system is working properly, if you get a proper tracing. And whenever you get an abnormal tracing, the first thing I do is listen to the heart. And I say, does the heartbeat I'm hearing follow the pattern that I'm seeing? Okay, and that's just my big take-home message is nobody should ever look at an ECG and freak out without picking up a stethoscope and listening to the heart. And I've had students time and time again look at an ECG and they start to freak out. And I'm like, feel that dog's pulse, feel that dog's heart. Even if you do not have a stethoscope, put your hand on that heart, feel something. Hell, put your ear to the dog's chest, for God's sakes. You see what I'm saying? So, you gotta do what you gotta do. I'm not saying that you can't see an ECG and be, I've looked at ECGs before and it's got my heart going and I'm like, oh, I don't like this. But the very first thing I do is confirm if what I'm seeing is what I'm hearing, because there's a lot of times I listen and it doesn't match that. And what I'm hearing is much more important than what I'm seeing. That's all I'm saying. We'll get into that more. Now, we've talked about this blood flow, showing you here. The vena cava has brought that blood back. You see it's kind of yellow, you could blue. It goes to the right atrium, tricuspid, to the right ventricle, through the pulmonary valve, out the pulmonary artery. And you remember, I added a step in anatomy. I put an arterial here, then pulmonary capillaries, because it's going to go through an arterial, which is a small baby artery. Then it's going to go to a capillary, okay? Then it's going to go through a pulmonary venule to the pulmonary vein, enters left atrium, mitral, left ventricle, aortic valve, aorta, systemic capillary, systemic veins, which means the body. And in anatomy, I've always told you, I'm like, that's the spot where in the capillaries now, I say just pick an organ, kidney, liver, intestines, big toe, wherever. It's going, everything needs oxygen, so it's going somewhere. If you look, and I know this looks weird with all the arrows, but it's basically showing you that it's going from systemic circulation After systemic circulation, the body uses the oxygen, comes into the vena cava, right atrium, through the tricuspid to the right ventricle, pulmonary artery, lungs. It picks up its oxygen. That's spelled wrong. Pulmonary vein, left atrium, mitral valve, left ventricle, aorta. And you see it's like a continuous cycle. So the left side is oxygen, right side is blue, which is deoxygenated. Okay. So I do want you to be familiar with that blood flow. Do want you to be familiar with that blood flow. And again, important structures, the pericardium. Anytime you have a lining of something, pleura, peritoneum, pericardium, whatever, it has parietal and visceral. Okay, visceral is the side that you would see. That is the side that connects or faces the organs. The parietal is what's facing the heart. Okay, so visceral always means organ, and that's what we would see. And again, it's not on this slide, but remember there is fluid. So it's supposed to be pericardium, fluid, and then the heart. And that is supposed to provide a buffer for the heartbeat. And then myo is the muscle, endocardium, epicardium. Now, I don't see many issues. I don't talk about epicardium as much as I talk about myocardium and endocardium. Myocardium is what's implicated in a lot of diseases we see. It's a disease of that muscle. And then the endocardium can get inflamed. Like I will say, we always recommend dental health, because if you have a dog that has a really crappy mouth, a lot of bacteria, it can flow through the bloodstream because the teeth are rooted in the gums, which is very rich with capillaries and blood flow. So bacteria, if it migrates up through the teeth and it starts circulating in the blood, a lot of times that bacteria will seed or connect to those valves in the pulmonary artery, or the pulmonary valve, the aortic valve, mitral, any of those valves. And then that bacteria kind of attack that valve, and you get that, and it can also go into the lining of the heart. You get this endocarditis. So there have been times we get these really bad dogs that come in for a dental. We'll send them home for 2 weeks on antibiotics before we do the dental, because we're like, we're going to scrape all that and cause all this irritated gum, and that could potentially release more of that bacteria. So sometimes 2 weeks of let's treat this infection and then let's do the dental. So we have had cases we've had to send home and say, we'll wait just to be safe. So I talk about endocardium, I talk about myocardium, definitely talk about pericardium. And as a review, we talked about this once in anatomy. Anytime we're talking about venipuncture, vein, so we're talking about jugular, cephalic, and obviously we're familiar with what species. Saphenous vein, now in the cat, you can use the medial saphenous, which is near the stifle. If you draw blood from a cat on the upper thigh, closer to their body, that's the femoral vein. So if you go up really high on the cat leg, and that's the most common site in a cat, I would say jugular and femoral vein, which is on the medial aspect of the hind limb, are the most common. If for some reason, sometimes in chemotherapy in cats, we would use the medial saphenous, and again, it's lower near the stifle and sometimes easier to hit. Now in a dog, we use jugular, we use cephalic, and then we use the lateral saphenous, which is down. I know that looks like it's over his thigh. It should be down here near the hock. Now, if you have a giant cat, I think there's once, maybe twice, we've actually hit the lateral saphenous on a big old monster cat. Most of the time, you can't really see that well on a cat. But on a dog, femoral vein, they have a meatier kind of thigh, think of it that way. So when you go to hold up their back leg, it doesn't pop up nice like on a cat. Maybe you got a little like white foo-foo thing. You might be able to wet it down and see that vein, but most of the time, It doesn't show up very well. So that's why we tend to use the lateral. And then in the cow, you got jugulars, obviously, and the horse is the jugular. I mean, in the horse, really all you got is the jugular. In a cow, they do also have a tail vein, similar to what you would do in a rat. It's on the ventral aspect of the tail. You lift up their tail, and it runs right down the median aspect of the tail, really close to where the tail is in the body. You're not going to do this up at the tip of the tail. Okay, so the vein is big near the base of the tail, and it gets smaller as it goes to the tip of the tail. So you would do this low. Now, there are times when you need to get an arterial sample. Now, in dogs, this is typically for critical surgeries, doing blood gas, because if we're testing for oxygenation, the gold standard is because arteries carry oxygenated blood. Now, the dorsal pedal artery, if I go back to this dog picture, it's on the medial aspect of the paw, the dorsal aspect, dorsal medial, right about where they bend their paw. If you were at home, and sometimes when Bo's sleeping next to me because I'm weird, I used to have to put in arterial catheters all the time for surgery patients. You literally can put your 2 fingers there, right over the little medial aspect, right below the hock where it bends, and you can feel the pulse. I can feel it on my cats. My cat's sleeping, sometimes I'll put my little, because I'm just weird like that. I'll feel right there, and you can feel a little pulse, 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 pulse right under your fingers. You can hit that. That's actually the site where we would put most of our arterial catheters, would be in that dorsal pedal artery. The femoral artery is the same way where you would get blood from the femoral vein. And when we did dissection, I said, you can see where the femoral vein was. The femoral artery is usually right underneath, but the artery is a little bit deeper. So I will tell you, when you're drawing blood from a femoral vein, as long as you're not like this, drawing blood, if you're like, if this is the leg, you want to be kind of shallow. When we go to hit an artery, we have to go a little bit deeper. I usually feel for the pulse on the femoral artery, and you almost have to kind of like stab at it. And I know that you can't just push real slow because the artery is muscular, and if you tap it, it'll bounce out of the way. And then all of a sudden you're feeling, you can't feel it. I mean, it's there, but the artery's like, don't hit me, don't hit me, don't hit me, don't hit me. I feel like my visual artery. But it is true. You'll hit it, and then I'll have to move my fingers and be like, where'd you go? The femoral artery is good for sampling for like a blood gas, maybe a once or a twice thing. You do not catheterize the femoral artery. Okay, if we're going to put an IV catheter, we would put it, or use a catheter, we put it in dorsal pedal. There is an auricular artery in the pinna, and sometimes in swine. That's if you're working with swine, and a lot of swine are used in research. So if you go into research, you might work with pigs. And in a horse, they have facial arteries. We talk about that in anesthesia when we talk about equine anesthesia. So we talk about the facial, there's a mandibular artery, there's a transverse facial artery that you can use, and you can use a dorsal pedal. If you work with horses, if you think you want to work with horses and do surgery, you will put an arterial catheter in almost every horse because blood pressure is key for their muscle blood flow, and you do a lot of blood gas sampling when you work with horses. So I want to say every horse that had surgery at Purdue had an arterial catheter placed. So, okay. Now, when you're listening to the heart, and this is obviously great when you have a big old tank of a dog that has a nice heart rate of about 50 or 60. This could be good with your dogs at home when they're sleeping, because at sleeping, they should have their lowest heart rate, which is called their baseline. Remember, systole is contraction of the heart. Diastole is when it dilates or relaxes and fills with blood. So systole is usually heard between the first, and I say first and second sound, the first is lub, the second sound is dub. So it's supposed to be lub dub, lub dub, lub dub, lub dub. I've had people sometimes count those heartbeats, 1, 2, 3, 4, 5, 6, and all of a sudden they'll give me I'll look at this big giant dog and they'll say, yeah, the heart rate's like 140. And I'm like, you mean 70? You know, and so sometimes, and you know, that just is a common mistake, no big deal. But your pulse will help you figure out, because lub-dub, you would feel one pulse. So that's why we say it's good to try to feel a pulse when you're doing a heartbeat. It'll help you kind of check your math. Diastole is usually between the second, so after the dub and before you hear the next one. But I basically, lub is the AV valves going close, and then dub is the aortic and the pulmonary valves closing. Now remember, the AV valves should open and close before the pulmonic and aortic valves open and close, because the atria contract before the ventricles. And you're listening for good doom, doom. And when you hear that bump, 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 nice and crisp, that's good closing and snapping of those valves. Like I said, if you've got a cat that has a heart rate of like 200, are you going to be hearing lub-dub? Probably not. Not unless you got some big chill, like male cat, and he's like super chill. Sometimes you get a nice slow chill. But you know, most of the lowest heart rates I hear in awake cats are usually somewhere in the 140s. So that's about as relaxed as a cat's going to get on average. But make sure you know which valve, what's closing when we have these sounds. And when you listen, we're trying to listen at the second or third intercostal space. And you can do from the fifth to the sixth. And now, this is where what they're saying, when you go up to the second or third and the fifth or the sixth, it's really going to depend on the animal. But I will tell you, even on this, is cats, I find that their hearts are a little bit more caudal. So sometimes if you go in the spot on a cat where you would a dog, I've had it where I can't hear the heart, and then I slide my stethoscope back and I'm like, there it is. Now, what I've really told you is, if an animal is standing, normal position, this point of the elbow is their olecranon. About, if they're standing and their olecranon is against their thorax, if you slide under that olecranon, that's about where the heart should be, if they're standing in a normal position. So I always say, kind of like, slide your stethoscope under. You don't want to go up in the armpit. You kind of want to just go where they're standing normally. And again, the heart is a little more ventral, so you don't want to be up on their chest. You want to try to get, because the heart lays about like this on an axis, and it does point a little more ventral. And it does, the base of the heart in the thorax lays about where the sternum is. So it should, and I will pull up some x-rays to show you some hearts, but remember, this normal kind of axis of the heart, it's not supposed to be straight up and down. It's not supposed to be pointing cranially. The apex, which is the point at the bottom, should be pointing a little caudal. If our heart's up like this, could something be pushing my heart up out of the way, like a mass in the chest? Potentially. So that's why heart position on an x-ray is diagnostic, because if it's not in the right position, there's probably a reason it's not in the right position. And then we do some investigating. What I'm going to do right there, I think, well, okay, this is telling you, I'm not going to get into point of maximum intensity. When a doctor is diagnosing a heart murmur, we're trying to figure out which valve is affected. I probably stopped for a second because I got the little sign, so basically what your job is when you do a physical exam on a dog, or you do your intake exam, I will just go to the doctor and say, hey, I hear possibly a murmur. I hear an abnormal heart sound. It is their job to go in and tell me what grade of murmur, and them to potentially figure out what valve. So what this slide is telling you, you can listen at different spots on the heart and it will tell you potentially where the issue is, what valve, what area. So if we look at this picture, it's telling you this is obviously the left side, this is the right side. Remember, the heart points a little more to the left. So you're going to hear a little bit better sounds on the left than the right. But this would be the doctor's job. I think what I'm going to do, because I want to get more into this, and I'm going to stop here. So we'll pick up a little bit more on this murmurs. I will work on a homework sheet and I will get that sent out. I got to get some stuff ready for anatomy, so I'll probably send that out after my other classes. So look for that this afternoon, and we'll pick up on this tomorrow. Actually, hang on a second. And I hear the dog pacing at the back door, so I may have to run to him really quick. So if you're done, make sure you type chat. If you have a question, let me just get to him really quick. You can stay on. If not, I will see you tomorrow. Okay? I'll be right back if you have a question. If not, okay, because like I got to get him outside real quick. Hang on. Or if not, I'll see you tomorrow.